Check. We are live. Just wait for 2-3 minutes. If it's showing in MB.
Good evening. Today we are going to have a live session on comprehensive cancer care, which is led by Dr. Swati. Dr. Swati is the director and consultant at pain and palliative department at Cytecare Cancer Hospitals. She is specialized in interventional pain management and has experience in handling cancer pain in specific. She has both national and international research publications on pain management, cancer pain. So therefore, she could be the best person to enlighten us on this topic, comprehensive cancer care. So Dr. Swati, could you tell us what is comprehensive cancer care is?
Thank you, Shamin, for the wonderful introduction.
Thank you.
So coming to the comprehensive cancer care. Cancer care has many treatments for itself. So what would be an ideal or a holistic care for cancer to any patient would include the medical treatment, what we offer. It could be the surgical, it could be radiational oncology. So put together all of this with our traditional methods of treatment, what I said, along with evidence-based therapies, which include our yoga, meditation, exercise, etc., which help a patient to go through this entire spectrum of cancer treatment holistically, is what we call as comprehensive cancer care.
So, in a comprehensive cancer care team, who are all included?
Ideally, in a comprehensive cancer care team, we have people from the medical background who are treating specialists, which I already mentioned. Could be the medical oncologists, could be the surgical oncologists. They are the palliative care physicians, including the pain physician. Could be a pain physician, an interventionist, interventional who does an interventional pain treatment. Alongside, you have a psychotherapist, psychologist, as well as nutritional supportist and the rehabilitation expert. We also have other experts like psychologists as well as yoga experts.
Okay. So, could you please tell us like their roles, each one's roles, like what psychologist's role is, physiotherapist's role, what, not in an elaborate form. I know that you are not from that background, your focus is on pain management and palliative care, but still some light on what they do, what they can do.
See, a cancer patient, while he's going through the treatment of cancer, will have a lot of side effects. If these side effects could be the disease related per se, that is the cancer ongoing, as well as the treatment which is being ongoing on the patient. So out of these both put together, the cancer patients have huge amount of disease burden, symptomatology, including diarrhea, constipation, nausea, vomiting. Besides all this, they also have other issues like the emotional, spiritual, etc. So when we have a team like I already mentioned, each and every unit or every member of this team has a specific task. For example, you asked me about the nutritional experts. When a cancer patient is going through the treatment of cancer per se, he needs to have a good amount of nutritional support to support this cancer ongoing chemotherapy or radiation therapy. So the nutritionist plays a very vital role over here so that the body does not deteriorate or the functioning of the body keeps up with the ongoing cancer treatment which is going on. So a huge amount of background work goes into each individual's body constitution type. So the treatment which the patient is receiving. So a nutritionist is the best one who decides upon what kind of calories and what are the specific components that these calories will be
Okay.
derived out of. Say like it is the carbohydrates or the proteins or it is the vitamins. So a nutritionist makes a best plan for the patient so that enhances the whatever medications have been given and the patient gets the best out of it. Immunity has a major role to play in cancer patients because once they are on chemotherapy, the immunity naturally goes down, the cells go down, that's the work. So therefore, again, we need a lot of immunity, and that we get from the diet that we take in, as I already mentioned.
Yeah.
So a lot of vital nutrients, whether it is to be achieved out of dry fruits, or a combination of this, or a combination of proteins, that all will be decided upon by the nutritionist. In addition to that, the nutritionist also decides when exactly she or he needs to be shifted onto any other form, which is the parenteral form, or it could be a supplemental form, where the patient may not be able to get all of this from the oral intake itself. Coming to the rehabilitation expert or the physiotherapist, while the patients are going through this treatment, in the course of the treatment, they do have a breakdown of the body, the muscle breakdown, the fat breakdown, and they have fatigue. So all these issues have to be countered. So the body needs to be kept up in the same fashion as it was. If not, going down the slope, at least it should be able to maintain the way it is. So a rehabilitation expert or a physiotherapist gives tailor-made exercises for such a patient. So any group of muscles which is required, whether it is the leg muscles or the chest muscles, the abdominals or the upper body. So physiotherapist plays a vital role in keeping up the such build of the patient.
Okay. So you have mentioned in that comprehensive team, pain and palliative team would be the topmost. So since you are heading the department of pain and palliative at Cytecare, could you please tell more about what is palliative care, what you do under palliative care, what are the treatments?
Yeah. So ideally, Shamim, palliative care does not mean that it is the end of life care. That let me just clarify it for the audience, because a lot of people have huge amounts of delusions about what palliative care is. So does palliative care mean the end of treatment or the end of life for a cancer patient? No, it does not. It should ideally start or begin the day the patient is diagnosed with cancer. Right? So as I mentioned, that there are huge issues, whether it is physical issues, along with that there are other emotional issues as well, spiritual issues, financial issues. Cancer patients have a lot of these burdens. So all of this put together needs to be taken care of. So in a comprehensive cancer care, we plan all these things together. When it comes to palliative care, as I mentioned, there are a lot of issues like diarrhea. The patients could have constipation or feeding issues or oral mucositis, oral care, dental care. All of this forms the part of a treatment, ongoing treatment for a cancer patient. All of this is taken care by the palliative care team. Besides this, what is going to happen to the body? Every patient has a right to know what is the diagnosis. So forming a communication channel or the lines of these channels with the patient at the earliest is the most prominent feature of palliative care. The patient has the right to know what he is going through, what his body is going through, whether he is going to get better, whether it is going to get worse, or does he have enough time, does he need to do anything before that. All of that gets addressed by the palliative team. Or the palliative care.
So as a palliative care physician, you strongly believe that we have to communicate to the patient about his diagnosis, prognosis. So do you think that it is very important, or it is like, see, mostly when we practice as a psychologist, what happens is like people will be like asking us not to reveal the diagnosis. So what your take on that? Whether we have to communicate to the patient? So we call it as collusion, right?
Right.
So is it important that patient should know, or is it is not that important? It is like it is.
No, I
yeah.
feel in my own perspective and even in the perspective of palliative medicine as such,
Okay.
we have been taught this way, and that is the right way to go about. Each person has the right to know what their body is going through, without raising false hopes about a treatment which is probably not going to work for them, or they may have come to a stage where the treatment may not work for them, or they may still be in a stage where a lot can be done and the disease is reversible. Every patient has a right to know what is happening. There could be so many issues. As I mentioned, there are issues. Cancer patients have huge issues, emotional burdens, huge years of savings, small, huge earnings and small savings, as I should mention it. So they have every right to do or decide what they need to do with it. They probably have the need or urge to probably talk to somebody, let out some emotions. They probably have, they could be having financial issues. So everything needs to be addressed well in time. It's called the care of goals or planning in advance for the final settlement. It's, cancer or a terminally cancer patient is like a person going in for a journey or a final journey.
Yeah.
So wouldn't you want, when you are going for a journey, to plan your things the way you would want to? You would want to take certain things with you, or you would want to leave certain things behind, or what happens to the house when you are not there around. You would want certain directives to be sorted out right at the beginning. So I think all of this makes a lot of sense for anybody who is going through that kind of a thing, to know what is happening with them. So I think I've answered that question. Everybody has a right to know what's happening with them. Yeah, the only point that I would mention over there here is, yes, we need to, as care physicians, palliative care physicians, or even as oncology doctors, we need to have a little bit of heart. We need to decide upon the timing, or we need to, I should say, tailor down or look at the right opportunity, how to put it in the right way. I do not say you put a message across very crudely the first time the patient has come to you, but never ever step away from revealing the truth to the patient.
Okay. Yeah, that was my the other question, but without asking the question, you have just answered it. So basically, palliative care is like, what from your talk, what you understood is like, you are giving a comfort care for the patient and a quality of life. So what would be the ideal time to start a palliative care treatment, or when the patient has to come under a palliative care team?
See, that's what I mentioned.
Yeah.
Unfortunately, in our country, the palliative care does not begin with the time the diagnosis is made of a cancer.
Okay.
But ideally, in the West, or even in some hospitals in our country as well, the time the patient is diagnosed with cancer itself, diagnosis is made, the patient is referred to the palliative care team.
Okay.
And then thereafter, if at all, once the palliative care team forms a rapport with the patient, it takes care of everything. It takes care of the practical issues of the patient. It takes care of the physical, not only the physical issues of the patient. So whether it is to do with the physical pain, or it is to do with the emotional pain, or it is spirituality, or it is finance, it is any of those issues that needs to be addressed right in the beginning. So ideally, it should be right at the beginning of the cancer diagnosis itself, or any time in the initiating treatment when you start for the cancer itself. It should be a part of the entire conglomerate of that.
Yeah. So during your talk, you have just mentioned that palliative care is not end of life, all those things. So, but see, basically, there is a belief in the society that if you enter into palliative care, or if you refer the patient into the palliative department, so this team will not do any treatment. So, can you tell more about that? What all treatments in, like some people used to tell they don't give antibiotics. Some people will tell it's only pain management, not more than that.
Right. I think I'll share an example over here.
Yeah.
Like for example, we have any lady who comes with a breast cancer, undergoes a mastectomy, and it is in the stage where the disease is completely cured and the patient is under surveillance henceforth. Now this lady will have certain issues which could be a body image, right,
Yeah.
which is distorted, which has a lot of scars on it, but still the woman is surviving with this.
Yeah.
Imagine the amount of emotional burden that is there. Of course, it's an image for the woman which has gone away. There are so many other similar issues like social issues, whether she would be accepted or she would want to go into the society. So there are helps which we can provide. Lymphedema is another issue.
Yeah.
Swelling in the arms which such a patient develops post mastectomy. There are lymphedema clinics which can really help ease the burden of the lymphedema and reduce the swelling, etc. Hair loss associated with the chemotherapy
Yeah.
is another such issue. So all these issues otherwise are going to lie with the patient, and the patient, even though is cured of the disease, maybe completely cured of the disease, but what happens to the patient down the line with all these burdens disrupts completely the personal life of the patient, whether it is it at the personal level or it is at the social level or economical level. It brings down the social image of such a patient. In palliative care, we help to get this back.
Okay.
So we give them emotional, whether it is the talks, whether it is cognitive behavioral therapies, it is yoga, meditation, exercise, and other body shaping products as well. Could be like wigs, artificial breasts, implants, etc., which again restore back the confidence that this patient may have lost. So this is one of the examples I just cited. Similarly, there are other spheres as well wherein a patient can have these issues, and we as palliative care as a unit can help them alleviate all these.
Okay. So another important point which I believe in palliative care is like when you prescribe as a palliative care physician and as a pain physician, when you prescribe some narcotic drugs. So for example, morphine. So there is a morphine phobia. People were like more concerned about its side effects. So is it that we should worry about the side effects, or we should not worry about the side effects?
Okay, so I think let me approach this question from a different perspective or a different way.
Yeah.
Nowadays, we have moved to an interventional management of pain,
Yeah.
wherein we reduce the burden of all the opioids. Of course, you must have heard about the opioid crisis worldwide that happened, and opioids do have their own side effects when they are used in huge concentrations and larger doses, which of course cancer pain is dynamic. It keeps changing, it keeps escalating from one day to the other. And the mechanism by which this occurs, it's got so many mechanisms. It's got a neuropathic mechanism, it's got a tumor burden, it's ischemic. So there's so many factors which contribute to and the psychological factor as well, which contributes to this pain. So these pains are like really dynamic, as well as they are very, very severe to handle. Now, yes, morphine or opioid, if we say, is that a panacea? In today's world, I would say no. Because we have moved, technology has moved to the stage wherein now we do avoid using the higher doses of opioids by interventional pain management.
Okay.
So by doing interventional pain management, these are minimally invasive procedures which do not require really any general anesthesia or regional anesthesia, so to say. They just can be done under local anesthesia, and as much as even you would have heard that the tumor, once it spreads, it may go into the spine, so it may make the spine very brittle and break down.
Yeah.
So in these patients, either they have the choice or option of being bedridden or using braces, but still the quality of life is not good, or be on very high doses of opioids. So here the the use of or the essence of interventional pain management has really or drastically change the face of the way pain is managed in these patients. So percutaneous vertebroplasty is one such procedure wherein it's just an injection of a cement through a white bore needle into the patient's vertebra where there is a fractured fragment or it's a wedge compression fracture.
Mm-hmm.
So similarly, there are other interventions as well, like radiofrequency ablation or neurolysis, which can be done for these patients, depending upon which part is giving the maximum pain to them. So interventions come in a very starting role to say, though the earlier guidelines or earlier practices were that they be left till the last minute or something. But as the new guidelines come in and the new evidence suggests that these interventions should form the mainstay, or primarily they should be the ones to be taken up first, avoiding the over medication or overuse of opioids.
Okay.
Now coming to your question that you said that should the patients really worry about it? Opioids do have their own side effects: constipation, sedation, nausea. Already a patient who's having a burden of cancer cannot eat much. Over and above that, when we induce opioids, the appetite even goes down. There's vomiting, there's nausea.
Mm-hmm.
So they do have their own side effects. But when we combine, so we have to when in a cancer patient, we have to come to a balance between using the right amount of or the minimal amount of opioid along with interventions. We can bridge this gap and take out the patient successfully out of a painful scenario and make life very comfortable for these.
Okay.
Now saying like I totally want to avoid, or if patients totally want to avoid being on any pain medication or especially opioids, to say, I think that it needs to be really clarified with such patients or in the general crowd that addiction does not happen usually in cancer patients or usually in scenarios where they do require to be treated. Addictions happen, or the risk factors for addictions are those patients who already have a history of substance abuse, or anybody who has psychological issues, or anybody who has had a past history, as I mentioned, of alcohol abuse or anything like that. And if a patient is not having a pain per se and still is trying to use this, those are the conditions where you say that addiction happens. In cancer patients, the burden of the disease, the pain is so much that it usually never comes to an addictive state or scenario.
Most of the patients and caregivers especially are worried about the addiction factor.
Yeah, it's a myth in the society which exists that we will get addicted if we use. Nobody gets addicted with 40 milligram or 60 milligram of morphine. But that is the dose that we usually start or initiate any patient with. So I think they can go with a liberal mind. And the pain physician who's treating them knows the best whether it is required for the patient or not. So if you are advised for it, my advice would be to go with it and do not suffer. There's this saying that pain is inevitable but suffering is optional. So we choose the option whether we want to suffer with that pain or not. So nowadays when we have so many best interventions and when we have so much of advanced technology and medications, I think it's totally, it would be futile on our part if we are not able to elevate that pain.
Yes. So in cancer, especially in cancer, would you say that palliative care and psycho-oncology should work together? And what is the importance of psycho-oncology in cancer setup, according to you?
Okay. See, as I mentioned right from the beginning, I have been going on saying that cancer patients have huge amounts of emotional issues. Bereavement, if at all it is coming to, or acceptance, breaking the news, breaking a bad news. It's not a quick walk for anybody to accept that life would not be the same, or how it is going to be, whether there is going to be dependence on anybody else, how my body is going to react to the treatment, whether I am going to stay alive or not. So all of these are huge emotional issues which may not be satisfied or which may not be answered by the patient himself, or he may be in a delusion all the while. So a psycho-oncologist plays a very, very vital role in these patients. It helps to take the complete burden of the emotional aspects from such a patient, and equip them in, first of all, accepting the reality that the disease has happened. Acceptance of the diagnosis itself is a big challenge in most of the patients. Once that happens, then only you start making the next step. When you don't take the first step of acceptance, you can never come to the second step of how to deal with it.
Yeah.
So that way, I feel the psycho-oncologist, thanks to you,
Yeah.
forms a great support to not only the pain department or the palliative care department, but also to the other oncologists, the medical as well as the surgical oncology.
Okay. Thank you for that. So we have one question like, does opioids affect immunity?
No, opioids do not affect immunity. There is no evidence to say that opioids affect immunity. Immunity is only boosted, as I mentioned, by nutrition, nutrient diet, and healthy ways of practicing, whether it's yoga, pranayama, meditation, exercises, and your good nutritional support, which is derived from your vegetables or plant-based or animal-based, whatever you are comfortable taking.
See, one more question what I want to ask is, like, when we talk about palliative care, there is one more word comes, like end of life. So, just in short, what is the major difference between palliative? You said that it is not, palliative care is not end of life, but what is end of life care and what is palliative?
I think I have already spoken a lot about what is palliative care.
Yeah,
so
yeah.
now going to end of life care.
Yeah.
End of life care is something which you know that this patient is not going to, any cancer patient is not going to make it through and eventually is going to have a terminal end. Now, does this patient need to go through that suffering towards the end? Or you as a caregiver or a relative of the patient, do you want to see the patient struggle through those last 1 week of the suffering? The suffering could include pain, it could include anything to do with feeding. This also could deal or have to be with the breathing pattern. So it could all be making life very difficult for the patient.
Yeah.
There are other issues like ascites development, fluid development in the lungs and all, which makes it very difficult for the patient, such a patient. So would this patient go on like this? Would you want to see the patient struggle through towards the end, or would you want to have a comfortable end once you know that the time has come?
Yeah.
There are certain clinical parameters which I will not go into right now, but there are certain clinical parameters which a trained physician knows how to diagnose the end of life has come.
Okay.
Once having diagnosed that, then thereafter you initiate. There are many methods how you do this with, but usually we take the help of the drugs. We put them on infusions, and this is not to actually anticipate, or this is not to fasten the process of death, but just to alleviate the symptomatology and the trouble or the distress which the patient is going through, so that it is a comfortable. So most often the patients can breathe comfortably and they are sedated, so that the family does not see them through that death rattle and struggling, having that struggled expression on the face, which is very, very difficult for the loved ones to see their kith and kin in that state.
Yes, true. So we have another question: when should patients consider to consult pain and palliative care?
Sorry,
When should the patients consider to consult pain and palliative care?
As I mentioned right in the beginning itself, if a patient knows that he has been diagnosed, treating oncology surgeon or medical oncologist has given them the diagnosis, that's the right point of time that they should be coming to the palliative care department. And once the department knows about their disease and everything, we will know the prognostication about it. Whatever symptomatology arises out of the disease or out of the treatment, we will be able to take care of the same.
So, I think I have done with my questions, because I have planned this should be like this, because there is a general if you come to the society, when you work with patients, like when you go deep into their emotions and psychological issues, we know that patients have lot of anxiety regarding palliative care, and in community also people have certain kind of anxiety regarding palliative care. When people doesn't want to hear palliative care, I have seen patients like that. They don't want to hear palliative care word. They don't want to come palliative care team with an ambulance saying that palliative care.
Yeah, unfortunately, it's been like the same, and I think in our country, most of the idea comes with the feeling that if palliative care gets involved, then that means that we will not be given any treatment now.
Yeah, yes.
So it is not the same as not getting the treatment. Palliative care here is only to help you to take the treatment what you are getting from your oncologists, your surgeons, and at the same time, whatever disease or symptomatology is happening to you, we are there to help you. Is there anyone who can help you navigate around this whole thing? Whether it is your radiation, whether it is the issues arising out of that, whether it is pain, whether it is nausea, whether it is anything. Is there anyone you can talk to? Is there anyone who can guide you? So palliative care right from the beginning should be the one who should be consulted, and we can navigate the entire plan. We can make a system for you wherein it helps you, and it is evidence, it is research which has shown us when an oncology treatment or the cancer treatment has started side by side simultaneously, a palliative care treatment has happened. The symptomatology is much less, and the patients are able to go through the treatment in a much better way.
Yeah. Saurabjit Mukherjee, he has the very controversial question. Do you advocate euthanasia for terminally diagnosed patients?
Forget about advocating euthanasia. It is not at all in the jurisdiction of our government or our law itself.
Yeah.
The law does not, Indian law does not permit euthanasia.
Yeah. So we always, as psycho-oncology team, we always say that whenever a patient asks for euthanasia or ask for just kill me, something like that, so we used to tell that there is some lack in the care. So either it may be pain management. So if you have a good pain management, patients will not ask for euthanasia. That is what we use in cancer. Especially in cancer, we are saying there is a suffering. If somebody is asking for anything like this, there is a suffering associated with it. So you solve their sufferings, then there won't be any discussion about euthanasia.
The other thing about going a step before euthanasia is signing an advance directive, which is the end of life care. So there, yes, any patient has the right when he is in a state to make a will, or if not the patient, then the kith and kin of the patient can decide whether this patient needs to go for resuscitation or not. We know, like the law dictates us, if we find any patient or anybody who does not have a consciousness, lacks any cardiorespiratory activity, we initiate the resuscitation efforts, we intubate and take the patient onto the ventilator, hoping that the patient will come out of that. Now that is in a normal scenario, in a non-cancerous, non-malignant scenario. Here is the scenario when we have an advanced cancer condition and we know that it cannot be reverted back. So in this condition, if a patient goes onto the ventilator or in the ICU, it is only going to be hung to the ventilator. It is difficult to breathe through those ventilators, be more infected. The family gets completely emaciated because of the huge finances, as well as at the same time the worry that looms the entire family while they are not really with the patient but outside the ICU. So I do not really recommend, and nobody in palliative care recommends, that any patient should go into that scenario. So there's something called as an advance directive, wherein you can sign these directives and give in writing to the treating physicians that you would not want, if a natural course of cessation of life happens, you will not allow them to, or you will not advise them to, or you will not want them to resuscitate and be taken into the ICU on a ventilator. But before that, anything other than this, a treatment, whether it is for infection, whether it is for hypotension, whether it is for anything else, will be definitely given to the patient.
Okay. So I think with that question we can end this session. Thank you so much for joining us for this session. And on behalf of Cytecare Hospital and behalf of our Psycho-Oncology Department, we thank Dr. Swati and the participants who have actively participated in asking questions, and our entire IT team. Thank you so much.
Thank you, Shamini.